Assalamu alaikum. My name is Dr. Sophia Akbar, and today we are going to talk about the anti-protozoal drugs. Anti-protozoal drugs include antimalarials, drugs for amoebiasis, and drugs used for other parasites such as pneumocystosis, toxoplasmosis, leishmaniasis, and trypanosomiasis. First, we'll be talking about the anti-malarial agents. Malaria is, as we all know, is one of the most common disease worldwide, and four species of the Plasmodium commonly infect humans. These include Plasmodium falciparum, vivax, ovale, and malaria. If you look at the life cycle of the malarial parasite, it consists of two phases. First is the sexual phase, which occurs in the mosquito, and second is the asexual phase, which occurs in the liver and in the blood cells of the human. In the sexual phase, the female Anopheles mosquito, in the gut of the mosquito, the gametes fuse and the zygote is formed, which undergoes many divisions, and sporozoites are produced, which are then released through the salivary gland of the mosquito when it bites to the humans. And these sporozoites, they pass from the mosquito's salivary gland to the bloodstream and then to the liver of the host. And the asexual cycle takes place in the liver and in the blood cells. Merozoites are produced in the liver cells, and then they enter into the red blood cells. And when these red blood cells rupture, fever and the chill occur during the malaria. And if the spores and the toxins are poured into the bloodstreams, they are then converted into the gametocytes and then taken back by the mosquito. And this is how the asexual cycle ends. And however, some of the chazons, they remain dormant in the liver, and this dormant hepatic stage, which is known as exoerythrocytic stage, is responsible for the relapse of malaria. And this exoerythrocytic stage is absent in Plasmodium falciparum, so the relapse is not seen in Plasmodium falciparum. If we look at the clinical classification, it includes blood chazonticides, tissue chazonticides, and sporonticides. In blood chazonticides, these forms are killed in the erythrocytes, and these include chloroquine, quinine, quinidine, mefloquine, artemisinin, helofentrin, and atovaquone in the fast-acting drugs, and in the slow-acting, proguanyl sulfonamides, pyrimethamine, and tetracyclines are included. In tissue schizonticides, primaquine is the main drug, and it kills the schizons in the liver. In sporonticides, primaquine, proguanyl, and pyrimethamine is included. The first drug and the most important drug is the chloroquine. Its pharmacokinetics, it is rapidly and almost completely absorbed from the small intestine. It is rapidly distributed in the tissues, having a large volume of distribution of 100 to 100 liters per kg. And antacids decreases its oral absorption, and it is excreted in unchanged form in the urine. Uh, in its mechanism of action, it is concentrated in the food vacuoles of Plasmodia and thus inhibits the conversion of heme into hemosin. This increased form of hemosin is toxic to the Plasmodium and causes its lysis. The resistance mainly occurred by two mechanisms. The first of all, there is decreased intracellular accumulation by increased activity of membrane transporters. And in case of Plasmodium falciparum, it can also result from decreased intravehicular accumulation of chloroquine via a transporter which is inverted by a Plasmodium falciparum chloroquine resistance transporter gene. So these are the two mechanisms of its resistance. In clinical uses, it's the drug of choice for acute attack of malaria, for the prophylaxis of malaria. It is also used in amoebic liver abscess and in granulomatous diseases such as rheumatoid arthritis, SLE, discoid lupus erythematosus, infectious mononucleosis, and giardiasis. Adverse effects include GI adverse effects, and along with them headache, nausea, malaise, blurring of vision, urticaria. In rare side effects, hemolysis and G6PD deficiency can occur, impaired hearing, confusion, psychosis, seizures, agranulocytosis, hypotension, and QRS widening. Its contraindications include psoriasis, porphyria, retinal or visual abnormalities or myopathy, and liver diseases or neurological or hematological disorders. Second drug is quinine. It's also given orally. However, slow IV infusion is given in severe cases. It's rapidly absorbed and peak plasma concentration occur in 1 to 3 hours. It's widely distributed and has a large VD, so it's always given along with a loading dose. IV bolus dose is however contraindicated as it can cause cardiac dysarrhythmias. It's metabolized in liver and excreted in urine, and its half-life is about 10 hours. Looking at the mechanism of action, the quinine complexes with double-stranded DNA and prevents DNA strand separation. Thus, it results in block of DNA replication and transcription to RNA. The quinine, it accumulates in the lysosomes and binds to heme and thus inhibits the conversion of heme to the non-toxic product. This heme quinine complex is highly toxic to the parasites and thus causes its lysis. It can also disrupt lysosomal membranes. Uh, it's used for Plasmodium falciparum infections which are resistant to chloroquine. Quinine is used along with doxycycline or clindamycin to shorten the duration of therapy and also to limit the toxicity. Quinine is used in IV form in severe cases or in complicated falciparum malaria. It should not be, however, used routinely for prophylaxis. The major side effect includes synchronism, in which ringing in the ears and possible hearing loss occurs, headache, dizziness, visual disturbance, and blurred vision is seen. Rare side effects include idiosyncratic reactions such as rashes, urticaria, pruritus, disturbance in cardiac conduction, hemolysis and G6PD deficiency, black water fever, and which includes intravascular hemolysis, and quinine is contraindicated in pregnancy. Then another important drug is mefloquine. It's a synthetic 4-quinolone derivative. Because of its local irritation, it can only be given orally. Its mechanism of action is unknown. It is used for the prophylaxis in all areas with chloroquine resistant, and it's an alternative to quinine in acute attacks and uncomplicated infections resulting from Plasmodium falciparum malaria. Uh, its toxicity includes GI disturbances, headache, skin rashes, cardiac conduction defects, psychiatric disorders, neurological disorders including seizures. Then primaquine, it's a 8-aminoquinolone. It's given orally and it's rapidly metabolized, totally cleared within 8 to 12 hours. Its half-life is about 3 to 6 hours. Uh, it's a tissue schizonticide as we have already discussed. In its mechanism of action, it forms the quinolone-quinine metabolites, which are electron transferring redox compounds, and they causes lysis of cell by acting as cellular oxidants. It's used for radical cure of Plasmodium vivax and ovale, and in active cases, it's used along with chloroquine. It's the most effective antimalarial for preventing transmission. Its toxicity includes pruritus, headache, methemoglobinemia, hemolysis in G6PD deficient patients, and it's contraindicated in pregnancy. Next are the antifoliate drugs. These include pyrimethamine, proguanil, sulfadoxine, dapsone, and all of them are absorbed orally. They are excreted in unchanged form in urine. Proguanil has a short half-life, about 12 to 16 hours, uh, than the other drugs in this subclass, which have a half-life of greater than 100 hours. In its mechanism of action, the sulfonamides, they act as anti-metabolites of para-aminobenzoic acid, and they block the folic acid synthesis in protozoans by inhibiting dihydropyridine synthesis. The proguanil is bioactivated to cycloguanil. This pyrimethamine and cycloguanil, they are then selective inhibitors of protozoan dihydrofolate reductase. The combination of pyrimethamine with sulfadoxine has synergistic antimalarial effect, as it causes the sequential block of the two steps in folic acid synthesis. Uh, in this slide, we can see the para-aminobenzoic acid is converted into dihydrofolic acid and then into tetrahydrofolic acid, thus forming the DNA. And the first step is blocked by sulfonamides and the second step by trimethoprim. Its clinical uses include it's effective against Plasmodium falciparum, pyrimethamine and sulfadoxine in fixed dose combination, which is commonly known as Fencidar, is used in the treatment of chloroquine resistant forms. Proguanil along with atrovaquine is used in the form of Melarone for the chloroquine resistant malaria, and it's protective against mefloquine resistant Plasmodium falciparum strains. Its toxicity includes sulfonamides, skin rashes, GI disturbance, hemolysis, kidney damage, and drug interactions are caused by competition for plasma protein binding sites, and it can also cause folic acid deficiency when used in higher doses. Other antimalarials include doxycycline. It's a tetracycline which is used for the travelers in areas with multi-drug resistance Plasmodium falciparum. Then amidaquine, it's effective against chloroquine resistance strains of Plasmodium falciparum. It's also used in fixed combinations with artesunate. Hematological toxicity includes agranulocytosis and aplastic anemia. Dovaquine is used in the form of Melarone along with proguanil. It's a quinine derivative and it disrupts mitochondrial electron transport system in protozoa. It is used for the prophylaxis and in the treatment of falciparum malaria. It can cause GI disturbance at higher doses. It's also used as an alternative treatment for Plasmodium girovicia infections. Then halofentine, its mechanism of action is unknown, and this drug is active against erythrocytic states of all four types of malaria, including chloroquine resistance malaria. It's not used for prophylaxis as it can cause, it's highly cardiotoxic and hepatotoxic. Lumefantrine is a related drug is now used, which has a minimal cardiotoxicity as compared to halofentine. This is a table showing different drugs which are used in malaria along with their adverse effects. Then if we look at the prevention of malaria in travelers, chloroquine is the main drug which is used for prophylaxis in regions without resistance Plasmodium falciparum. Mefloquine is also used in resistance areas, in resistance to chloroquine. In areas with multi-drug resistance malaria, Melarone is used and primaquine is recommended for terminal prophylaxis of vivax and ovale infections. This table shows the drugs which are used for the travelers in areas with malaria, and as we can see that chloroquine is used in areas without resistance Plasmodium falciparum. Melarone and mefloquine and doxycycline are used in chloroquine resistant areas, and primaquine is used for the terminal prophylaxis of vivax and ovale. Next group includes the drugs used for amoebiasis. These are divided into two main groups: the agents for luminal infection which includes diloxinate furoate, idoquinolone, and paramomycin, and the agents used for tissue infection, which includes metronidazole, chloroquine, imidines, and tenidazole. This table shows the drugs which are used in different stages of amoebiasis. For asymptomatic infections, diloxinate furoate is preferred, and in mild to moderate intestinal infections, metronidazole is used along with a luminal agent. In severe intestinal infections, metronidazole or trinidazole is used along with a luminal agent. And in hepatic abscess and extraintestinal diseases, metronidazole or trinidazole plus luminal agent is used, and chloroquine is also used for liver abscess along with the luminal agent. Then the agents used for luminal infection. First is the diloxinate furoate. It's the drug of choice for asymptomatic amoebiasis, and it's also for the drug of choice for carriers. It's converted in the gut to diloxinate-free base form, which is the active amoebicidal stage, and the toxic effects are restricted to GI symptoms. It's metabolized in the liver by glucuronidation. Idoquinolone is the second luminal amoebicide. It's used as an alternative to diloxinate furoate for mild to severe intestinal infections, and it can cause iodine toxicity, which can lead to skin reactions and thyroid enlargement. It can also cause neurotoxic effects, including peripheral neuropathy and behavioral dysfunction. Paramomycin sulfate, it's an aminoglycoside antibiotic, and it's used only as a luminal amoebicidal. It's also used in leishmaniasis and cryptosporiasis in AIDS patients. Are the tissue amoebicides. First is imidines. Imidines and dihydroimidines, they inhibit protein synthesis by blocking the ribosomal movement along the messenger RNA. And these drugs are used parentally. They are the backup drugs for the severe intestinal or hepatic amoebiasis, along with the luminal agent in hospitalized patients. They can cause muscle weakness, GI distress, cardiovascular dysfunctions, and they are restricted to the severe amoebiasis when metronidazole cannot be used. Metronidazole is the most important drug in this group. It's given orally, it's readily absorbed, and it has a wide volume of distribution. Its peak plasma concentration occurs in 1 to 3 hours. Half-life of metronidazole is 6 to 8 hours, and that of trinidazole is 12 to 14 hours. It readily crosses the blood-brain barrier. Less than 20% is bound to plasma protein, and it's metabolized in liver and excreted in urine. Uh, it causes its action. The main group is the nitro group of the metronidazole, which is reduced in anaerobic bacteria and sensitive protozoans. This reactive reduction product is responsible for its action. It kills the trophocyte stage but not the cyst, and it effectively eradicates both the intestinal and extraintestinal tissue infections. Uh, it's used for amoebiasis, and it must be used with the luminal trophocyte in the luminal stage. However, it's the drug of choice for the treatment of extraluminal amoebiasis, and it's also used for the treatment of amoebic abscess in combination with chloroquine. Metronidazole is the drug of choice for giardiasis, Gardnerella vaginalis, peptic ulcer, pseudomembranous colitis, trichomoniasis, amoebiasis, and anaerobic bacteria like bacteroides and Clostridium. Its adverse effects include dry mouth, metallic taste, and it can cause paresthesias, dark urine, neutropenia, pancreatitis, and severe neurotoxicity. Taking the drug with meals decreases its adverse effect by reducing the gastric irritation. Its drug interactions are very important. It can cause disulfiram-like reaction, therefore it should not be given with alcohol. It potentiates the anticoagulant effect of fumarons. It may potentiate the lithium toxicity. Phenytoin and phenobarbital may accelerate its excretion. Cimetidine decreases its plasma clearance, and it should be avoided in pregnancy. It should also be used with caution in patients with optic neuropathy, renal or thyroid diseases, or in non-amoebic hepatic diseases. Chloroquine is also used in amoebic liver abscess. We have already discussed chloroquine as an antimalarial, and it's used where metronidazole is contraindicated or not available. Then the drugs for pneumocystis and toxoplasmosis. First drug is trimethoprim sulfamethoxazole. It's used for both for the prophylaxis and for the treatment of pneumocystis pneumonia. It's used for prophylaxis in AIDS patients when CD4 count drops below 200 cells per microliter, and it's also used for prophylaxis in toxoplasmosis. Its toxicity can cause rash, fever, neutropenia, GI disturbance, and thrombocytopenia. Pentamidine is the next drug which acts by inhibiting the glycolysis or interference with nucleic acid metabolism of protozoans and fungi. In its aerosol form, it's used for the prophylaxis of Plasmodium cerevisiae pneumonia, and IV or intramuscular form is used for pneumocystosis, for active pneumocystosis in HIV-infected patients, in which it's given for 21 days. Its toxicity occurs by IV use, which can cause respiratory stimulation followed by depression, hypotension, hypoglycemia, anemia, neutropenia, hepatitis, and pancreatitis. Next group is the antifols, which includes pyrimethamine and sulfonamides. As we have already discussed, both of them can cause the sequential block of the folic acid synthesis. Then pyrimethamine and sulfadiazine, and pyrimethamine with sulfadiazine and clindamycin. Atovaquone is also used along with proguanil in Malaron form. This Malaron form is used in malaria, and it's also used in pneumocystis pneumonia. However, it's avoided in patients with cardiac conduction defects and seizures. Then the drugs used for trypanosomiasis. The major drugs are pentamidine, melarsoprol, nifurtimox, suramine, and eflornithine. Nifurtimox is used for trypanosomiasis. Then pentamidine is used for the hemolymphatic stages of trypanosomiasis, and suramine is the drug of choice for hemolymphatic stages of trypanosomiasis. Uh, for leishmaniasis, the main drugs used is sodium stevogluconate. It inhibits glycolysis or nucleic acid metabolism in the parasite, and it's severely cardiotoxic. For visceral leishmaniasis, pentamidine, parabomycin, and miltefosine are used. For cutaneous leishmaniasis, fluconazole or metronidazole is used. And for mucocutaneous leishmaniasis, amphotericin B is used. Thank you.